Hello, my name is Tyler Bonkowski. I'm a second-year internal medicine resident at Spectrum Health, and I'd like to present a case of amiodarone-induced Torsades de Points. Amiodarone is a class 3 antiarrhythmic known to prolong the QT interval on EKG. Despite this, it carries less than a 1% risk of Torsades de Points, the thought being that blockade of multiple ion channels reduce its ventricular arrhythmic potential. So Torsades is set up due to this varying degree of repolarization that occurs throughout the myocardium as the QT interval prolongs. This is known as transmural dispersion of repolarization. So varying cell populations within the myocardium are refractory at different points in time. And the degree of this heterogeneity is actually reflected by the time from the peak to the end of the T wave on EKG, or the TPE interval. And as this interval prolongs, the heterogeneity within the myocardium increases. So in the instance of myocardial excitation of vulnerable populations of cells that are surrounded by refractory myocardium, you can get retrograde activation and subsequent development of a reentrant circuit, which then leads to ventricular tachycardia. The figure 1 at the bottom left-hand corner of this slide is from another paper, but actually illustrates really nicely an instance of depolarization occurring on a T wave, noted by the arrow in blue here, and subsequent development of polymorphic ventricular tachycardia. Of note, this patient also had a prolonged QT interval and a TPE interval, noted on the red bracket here at about 200 milliseconds. The patient was a 68-year-old female with a history of PVCs and non-ischemic cardiomyopathy with an EF at about 40%, as well as a baseline QT interval of 479 milliseconds, as well as bradycardia. Her baseline EKG is noted here on the right. She had started amiodarone 23 days prior to presentation in order to reduce her PVC burden, as it was thought that this was contributing to her cardiomyopathy. She presented after 2 episodes of syncope that occurred at a doctor's office. She was completely unresponsive and awakened spontaneously feeling flushed and confused. EMS was called, and she was placed on a heart monitor in the office and noted to have a ventricular arrhythmia with a wide complex noted here that corresponded to episodes of unresponsiveness. So she was taken quickly to the ED, and initial labs revealed normal electrolytes, and her presenting EKG was noted here on the right. Of note, the machine read her QTC interval at about 594 milliseconds, which, while long, was a little bit inaccurate, as measured manually, her QT interval was actually 764 milliseconds, noted by this red bracket here on the right. So the patient was started on a magnesium and lidocaine infusion. A transvenous pacer was also placed for overdrive pacing to induce tachycardia and rapid shortening of her QTC interval. The lidocaine infusion was gradually weaned as her QTC interval improved, and she had no further episodes of torsades or syncope during her admission. Given the iatrogenic cause of her torsades, an implantable defibrillator was deferred, and she was discharged with a wearable defibrillator as well as mexiletine, given it would take some time for the amiodarone to completely wash out from her system with its long half-life. Figure 2 is her presenting EKG with a prolonged QT and TPE interval. And if we compare this to figure 3, her EKG at discharge, we show improvement in her QTC interval down to 502 milliseconds, as well as her TPE interval down to 220 milliseconds. So this case highlights some of the additional risk factors for development of torsades, specifically female sex, baseline bradycardia, which in and of itself prolongs the QT interval, as well as reduced ejection fraction. This patient also had a prolonged TPE interval, which, as we mentioned earlier, puts her at risk for development of reentrant circuits within the myocardium. Notably, her QTC interval, when calculated on the EKG machine, was quite different from what we calculated and measured manually, and prior studies have noted EKG sensitivity to be about 54% when looking for prolonged QTC interval, so generally the machine will underestimate the degree of QT prolongation. So some of the take-home points from this case: amiodarone prolongs the QT interval and can cause torsades in the right patient, specifically those who are female, have baseline bradycardia, or reduced ejection fractions. The EKG computer has pretty poor sensitivity when it comes to detecting prolonged QTC interval and should always be confirmed with manual measurement and calculation. And lastly, the TPE interval can be used to further risk stratify patients for their propensity to develop torsades in the setting of prolonged QT. Thank you for your time.